again.
Oh, okay. And it always goes to the same place?
Yeah,
Okay.
so like that.
Okay. Excellent. Hey everybody. Thanks for joining Wednesday VMR. I'm Zaven without Steph today. And Vinny and Julia have a case for us to learn from. So I'm excited to hear about it and learn from all of you. Hey Soham, thanks for joining, man. Soham is one of our MS3s at Baylor. Or maybe twos. I'm sorry if I promoted you prematurely, so um, but and Seema will be doing teaching points, and Lyra, thank you for scribing. And since I'm all alone today, I'll need a lot of help. Steph's absence is no trivial gap to fill, so appreciate everybody sharing thoughts in the chat, and if folks are able to just weigh in verbally too, please welcome to him. All right, Vinny, Julia, you guys want to start telling us about the patient?
Yeah, absolutely. So starting with the first aliquot, I will just give you the patient past medical history so things can become more clear. So we have a 70-year-old male with past medical history of type 2 diabetes, currently insulin dependent, with diabetic polyneuropathy, hypertension, schizoaffective disorder, paranoid schizophrenia, bipolar, COPD, who presented with altered mental status about a day. So I'll stop here, leave you guys brief discussion, and then we can move on.
Thanks, Vinny. Um, people, we missed Steph already. Yeah, definitely. Um, okay, so people are probably sort of deploying a quick mist in their minds. Um, which is helpful to kind of keep all those possibilities in mind, even as we hear the history to generate new hypotheses and see what might connect. But even the past medical history, it's helpful to kind of anchor in the base rate, not of a general population, but in the base rate of what we already know about the patient, an older person with diabetes who uses insulin and who has lung disease, who has a serious mental health condition, a thought disorder. So I guess with that substrate, with our patient not being a member of the general population, but someone with those historical elements, are there like specific hypotheses that people are already thinking of to make sure to test? Hans is saying with the schizophrenia, definitely thinking about kind of effects of medications, absolutely. Um, Maybe high risk for metabolic things, and then infection is common in anybody. But yeah, Lyra, like that's an easy one, right? Like you use insulin, your blood sugar's 30 right now, like that's not a no longer a mystery, right? So I think that's really important. And Seema, you also mentioned an ABG. Um, I guess how does that connect with both the past history and the current problem? There you go. Okay, Fahid, thank you for answering the question. Yeah, at risk for hypercarbia, right, can cause altered mentation, somnolence, etc. And I also, it's cool that this patient's, I guess, substrate aligns well with some of the most kind of potentially rapidly fatal and rapidly reversible causes of encephalopathy, right? Hypercarbia, hypoglycemia, opioid exposure and overdose. So I think those are all things that in any patient, honestly, we should think of just kind of reflexively upfront, kind of no miss within the first, minutes. But then that this patient is at particular risk for. Um, so Awesome. Okay, I think with that we've started to kind of warm up and are ready to listen more intently with for the actual story if we have one. Because again, the realm of possibilities is just simply infinite, right? And I think the chief complaint and then the first few sort of elements of the chronology of the time course of the history um, so dramatically narrow that infinite uh, universe that I'm dying to hear it. I'll just mention one more thing is, as we listen to this story, the other possibility is just, that, we're described altered mental status, but there's some people think of, the manifestations of psychosis and kind of mental health conditions like schizophrenia as distinct from altered mental status. Like if this is just dysregulated, uncontrolled, psychosis in a patient with known a psychotic primary kind of a psychiatric condition, then I think the frame of altered mental status might be not that productive, right? So I think one thing we have to tease out early on too is this just this patient's schizophrenia that is active as opposed to everything else?
All right, amazing. Should we go for Eloquat
Yeah.
2? Okay. So he lives in a facility and he had been having augmentation for the past day and was brought to our service by the emergency medical service. So his caregiver at the facility informed that his baseline is AO times 3. He was lying comfortably in his bed last night and was AO times 2 oriented to self and place, and his speech is slurred, confused, and in this morning he was having difficulty to respond and AO times 0. So he was brought to reservice, and at this point was difficult and to enable to get further history, and we were not able to detain further details. So the most important part, that is the history, we were unable to obtain a such a comprehensive history. So diving with the research that we have, we reviewed the in the chart, and we could see that the patient was recently evaluated for his PSA by neurology, and he is being worked up. So 2 months ago, his PSA was 7.65, the total PSA, which is high. And the isoform PSA was also high, which was 27.3. And other than that, he was also being evaluated by general surgery for a left chest wall ulcerated solid mass, and was being treated with cephalexin by his PCP for approximately 1 month. But we are unclear about for how long the mass was there. So moving on with his about his meds, other than insulin, he takes rosuvastatin, risperidone, BYD, fluoxetine 40 ounce daily, valproate daily, also gabapentin, and he was not using inhalers at the facility for his COPD. And then we, at this point, when we were doing rounds and discussing the case with the emergency department, we tried to get further history. So we tried to find his family. In the chart, there was mentioned a friend as an emergency contact, but we were unable to read the friend. Then we tried to look at websites across the US, trying to localize family, look for the number of registration, his surname, and then all this kind of stuff. But we couldn't find any family. So consequently, we do not have a family history, and there were no records also of when the patient first arrived in the facility. And when we call it again, the facility, they don't know like anything about when the patient got there, any kind of family or friends. He didn't receive any kind of visits. And so moving on further than that, there's no history of drugs or smoke. We are unclear. And he's from Cleveland, does not have any allergies, and there's no recent travels or any kind of exposure. So I think that's a good point to stop.
Thanks, Vinny. Um, Yusuf, have you been able to kind of follow along? Do you want to, I'd
Yeah.
love to hear your thoughts.
I think the thing that struck me was a chest wall mass. And we don't hear that a lot. The reason we don't hear that a lot is that why would someone develop a chest wall mass and why would it cross the tissue planes there? And the tissue planes there, if you think about it, is like the skin, the muscles, etc. And there are only not a lot of things that like to do that. I think the few things that like to do that include like a malignancy. So I'm wondering if the patient has had like some form of malignancy, whether it's breast or skin that usually like ulcerated. And then even if we're thinking about infections, the things that like cross these tissue planes are actually rare. So like if it is an infection, which we will probably find out at some point with imaging, if we're thinking of infections that are subacute and cross tissue planes, the overlap of these two, I think, would make the differential very narrow, which includes like tuberculosis and blastomycosis, for example, to think of. But I'm curious to see the imaging that shows like a fluid collection or is it like a soft tissue mass? I think the differential is narrow there. Uh, yeah.
Um, yeah, I think to me too, the chest wall mass definitely was the biggest, densest sort of information that, it may very well be connected to his encephalopathy. But when you hear of any kind of ulcerating mass, it never happened overnight, right? In fact, the time course of something that is best described as an ulcerating mass is really, whether infectious or malignant, is probably kind of subacute to chronic, weeks, months, potentially, right? So, um, it is certainly a problem to be solved at or near the top of the problem list. But whether it is directly related to the one day, very different time course, of what is actually very significant altered mental status, and I'll go back to that in a second. That it could be or it could not be, right? So I wouldn't necessarily, I would almost like think about those problems in parallel because the altered mental status could be honestly still anything from those very simple no miss urgent things we need to rule out, the sugar, the CO2, the toxins, um, to again something that we haven't even mentioned yet, but I think Vinny, Julia, you guys like yes, there's not like a very clear story, but I think you did capture some really important findings that are extremely helpful. So, for example, the possibility that this is just sort of someone's baseline psychosis or just non-baseline psychosis, but exacerbated psychosis, um, quickly crumbled that hypothesis when you mentioned that he was A&O times only oriented to self. People with even with florid uncontrolled schizophrenia, psychosis, they shouldn't be disoriented necessarily to time and place and those things. They know exactly where they are and what date it is, and they think you owe them $500 trillion. Right? And they're completely sure of that delusion or whatever. But the fact that there's disorientation as well as the dysarthria you described, which is also sort of a neurologic failure, essentially, right? A neurologic deficit of not being able to articulate speech and make clear sounds with your tongue, with your palate, with your lips. Um, I think that too is kind of a medical neurologic problem to go along with the altered mental status, and could potentially narrow the frame of what's happening in the brain of the encephalopathy. Um, and I think I'm dying to hear the rest of the neuro exam to also understand whether there does seem to be kind of focality that is at play if, along with the dysarthria, there is also asymmetric weakness that would potentially localize to, vascular territory or even a focal lesion. You have this ulcerated mass on the skin in the chest wall. You could have some more of that in the brain, right, in the form of a mass lesion causing neurologic deficit. So, if the exam though is totally non-focal, sometimes dysarthria can be a manifestation of just sort of toxic metabolic neurologic dysfunction that is diffuse. So imagine somebody intoxicated with ethanol, right? Or who has who is very delirious from sepsis, or who's hypotensive, or who has had too much gabapentin or whatever. So when the brain is globally dysfunctioning, then even the particular articulate and motor function, cerebellar function, everything can be affected globally. And again, articulate speech is so difficult to produce, similar to walking, right? Similar to gait. So causes of global encephalopathy can predispose to falls, can cause the speech to be a bit slurred, and that doesn't necessarily mean there's like a focal cranial nerve lesion, a palatal weakness, lingual weakness, whatever. Um, so I want, of course, we need the vitals. I hope he can participate in some version of a neurologic exam, right? And then I think the meds too that people were also kind of reacting to in the chat. I thought that was very wise to think about, their potential anticholinergic effects, and potential for urinary retention and other impairment of neurologic function that they can cause, even in physiologic doses, but especially in accidental or intentional overdose, right? Any other thoughts, guys, that I missed? Somebody wants to emphasize? I'm not taking the chest wall too far. I think Youssef did that work beautifully, and David and others are also kind of building that. And yeah, I agree with all those possibilities. And yeah, hopefully there's a picture or more of a description too. But let's see what you have to share next.
So hey Lyra, if you can just share the imaging of the chest wall while we say out loud the exam, please. Yeah, go ahead.
Yeah,
So
just
going
1 minute.
Yeah.
Thank you. So going to the physical exam, blood pressure was 137/61, heart rate of 99, respiration of 22, febrile and saturating well in room air. AO times 0 obtained no verbal response, poor response to motor stimuli with pain and open eyes to pain. Also echo and reactive pupils, Glasgow Coma Scale of 7. He was edentulous. According to some notes from the past, the speech was clear and there's no history of strokes. Also, it was noticed a big tongue on the physical exam. On the respiratory bronchi in the upper right lobe, no wheezes and bronchial breath sounds was heard with dullness to percussion at right upper lung. Cardiac exam was normal. On the skin, as we seen in this image, there's a left breast of 4 over 8 centimeters mass according to the image, but bigger. The lesion had a full intense smell, and as being mentioned, they didn't know how long this lesion was present.
And also, I just like to preserve the patient. I just left it's not a official imaging of the patient. It's a very similar imaging from the internet. Okay, so yeah, move on, please.
So there's no other pertinent findings on the physical exam. And moving on to the labs, the white blood cell was 32, hemoglobin of 11, glucose of 438. On the EBG, pH was 7.45, bicarb of 26. Lactate of 1.9, troponins flat at 40s, lipase normal. UA shows pyuria, but no leukocytesterase or nitrates. X-ray of the abdomen on admission was normal, and UTOX was negative.
Also in the ABG, there like the PO was 100, and there were no signs of hypercarbia. There was in within the normal limits. And there was neutrophilic differential in the WBC, and other than that, yeah. Other than that, give me one moment here. Yeah, the patient was non-contributory to the physical exam. As I said, he was AO times, as Julia said, he was AO times 0 and very difficult to respond even in pain. So a discussion that was made at that point, and I, as just a medical student, I was very concerned why this patient's not intubated. And when I asked it and discussed it with the attendings and the senior residents, like the patient was stable, labs were normal, he could breathe normally, and despite having the low Glasgow Coma scale, and they decided to keep the patient on neurologic vigilance instead of intubation. So I'm sorry I cannot go further explaining about it, but that's what we have so far. Okay, I think that's a good point to stop also.
I'm so glad you stopped because there's so so much that we've learned in the last 2 minutes. And just two quick comments, Vinny. I think you justified both the reason to consider intubation as well as the reason you ultimately decided not to intubate beautifully, right? I think anytime you have somebody who is has a very low kind of GCS score, you want to think about whether there might be a neurologic process that could threaten the ability for somebody to sustain their respirations, right? And or depending on what else is going on, whether their airway might be threatened in the setting of a very diminished, gag reflex, cough reflex. But I do think sometimes I don't know if everybody here has heard a very old school kind of rhyming mnemonic that GCS less than 8 intubate, right? And I think that is very many people who don't need to be intubated have ended up intubated because of that dictum. And I think as you expressed and as your, team kind of judged, um, even if somebody isn't, responsive, awake, alert, etc., if they are essentially acting as if they're asleep, right? They're like deeply asleep, but breathing normally, and there's not, blood and stuff in their mouth that they're supposed to be coughing up, but they're not, then there's nothing necessarily acutely threatening their airway. And in fact, something that threatens your airway, which by the way is comprised of your larynx and of your vocal cords, is putting a tube through it. And anyway, so I think that you explained that well. And then Julia, I just wanted to comment when you shared the physical exam and the labs, there was so much there, like so much information you included that you summarized so beautifully and efficiently, and also built into it sort of what you chose to include and what you omitted also just reflected, really good kind of focusing on really relevant stuff, and prioritizing all of these abnormalities. So I guess people have started thinking about all of these things, and there's some great ideas in the chat. So the lesion to folks looks malignant, and I absolutely agree. Um, by the way, are there any signals that this might already be a metastatic malignancy? Any thoughts? Where could, if I were to tell you, or if Vinny or Julia were to tell us that in the end this turned out to be a metastatic malignancy, where would you guess the metastases are? highest suspicion. Oh, beautiful. So yes, totally agree. I think we have signals that there's something going on in the lung, right? And if we were to connect things, this could be a, pleural effusion. This could be lung metastases. And then there's a neurologic presentation in a chief concern, as well as just sort of the sustained, very abnormal mental status. We definitely need brain imaging to look for brain or CSF metastases. And then Hans, I love that you threw in the bone, and I wonder if we're thinking the same thing, but if this is a, by the way, the image that is centered, the mass is centered around a nipple, right? I didn't imagine, I'm not, is that correct? Okay. So if this is breast cancer, right, bone, lungs, liver are also three of the places where beyond lymph nodes where breast cancer is most likely to metastasize. So I think that's a very good hypothesis as well. Ooh, David, interesting. Dermis, is this a metastasis to the skin from somewhere else? Maybe. My assumption was that this was breast cancer in a male, which can happen even though it's not as common just because of where it was. But I think that hypothesis does make us need to look more closely at the rest of the skin to see. I think it would be a bit unusual potentially to have a solitary but such a large metastasis to the skin. But if you find other ones, that would certainly support that more strongly. Okay, and then the other thing that I want to kind of commend y'all's and totally agree with the important question of two things. So I forget who it was, but somebody asked about the calcium. Really important question to when you're dealing with somebody with encephalopathy and suspected malignancy, right? There would need to be pretty time-sensitive interventions, and if this patient's calcium were to be 14 or 18, and that looks like it didn't pan out, and then people are wondering this significant neutrophilic leukocytosis, and again, in a setting of kind of acute worsening of the clinical state and the mental status, if it represents infection, and that absolutely should be the first assumption until proven otherwise. And once proven otherwise, it is possible in a setting of a metastatic malignancy that this is reactive just from the inflammation, sort of, depending on how high the white cell is and what else is going on a smear, even like a leukoerythroblastic picture of just the bone marrow freaking out and immunologically driven by the malignancy. But we do need to look for sites of infection, both kind of routine lungs, urine, blood, but also realizing that again, there's likely a metastatic process that needs to be defined more thoroughly with cross-sectional imaging of the brain, chest, abdomen, pelvis, to get a bigger kind of better landscape of where the problems are and where further complications and complicating infections may be if this is a cancer. I'm also just kind of tracking and keeping in mind the possibility that this could be also an indolent infection, although I'm kind of that's on the back burner just a little bit because of both base rate as well as what seems to be a primary breast malignancy. But I might be wrong to anchor on that. And let's see where the case goes.
So some additional labs, liver function test, renal function test, and all coagulation panel was normal. The patient had some hyponatremia, 133, but no water electrolyte disturbances. And now we will go for the images.
Yeah, now I'll ask again Lyra to show the first imaging of CT, and then we'll give you some some time to share other images. And while she does that, I will review the report. So there was a speculated 4x4x4 write-up per low mass with associated satellite nodules centrally. There's also associated mediastinal and hilar lymphadenopathy. The findings likely represent lung neoplasm with nodal metastasis. And just a quick addendum before I continue to review the report. And there was a huge topic of discussion during rounds, and I love it that you guys touched base on is that a breast cancer, is that a lung cancer? So it was very difficult to see what is the pivot point of the case. And then we consulted like a pulmonology team, the IR, also the hematology oncology, and we did like multidisciplinary meetings to see like what is the best approach to what we can deal with the patient, what we're going to biopsy first, if we're going to biopsy, how we're going to do that, because the patient does not have a surrogate decision maker. And so now moving on with the report. However, metastatic disease from extrathoracic neoplasm should be also considered in the differential given the presence of the left breast mass. And other than that, the CT of the brain and facial bones was negative for acute processes. CTAP, no acute abnormality. There was also a MRI of the prostate from the chart review that was performed in the outpatient setting, and the patient had a right apex peripheral zone foci, suspicion for prostate cancer. So at that point, we are still in the ED, and it was started vancomycin and Sosan. It was given 1 liter of normal saline. The glucose was controlled, and the next aliquot will comment about the subsequent days of hospitalization. And just a provocative question for you guys, and then how do you conduct this case now? And if you want to do a biopsy, what is the place that you're going to consider doing the biopsy first? And do you want to do like just the breast, or do you want to go first for bronchoscopy? And how can you have the consent to perform these tests?
So yeah, I think really, really difficult questions. Go ahead, Youssef.
Oh, sorry. Thank you, Zaven. I think there's a medical term for this. It's called the unbefriended patient. It's the patient who does not have any family support or assigned like a decision maker like off the bat. And then the next questions are, one, is something like life-threatening going on? How much time do you have? And then the second question is that do you need somebody to decide or help decide with this patient? And I think in cases where the patient is unbefriended, it's state dependent, but if you have time, you can get a state appointed guardian to assist with decision making. If you have time. If you don't have time, you usually proceed to what you think is in the patient's best interest. And I think a lot of this times I would phone a friend and I would call like the ethics team to help with that, and they can help with finding next of kin, or even if somebody knew the patient but not their family, sometimes they can help with that to even see what their patient's preferences are, or if they expressed any preferences in the past in terms of like what they want in terms of medical decision making.
Thanks, Youssef. I'm just going to put in the chat a link to an article that's actually open access, but it's a sort of proposes a framework for how to think ethically about these situations where the patient can't consent, And in fact, a lot of times they won't even assent, meaning they like physically won't let you do something, right? And how do you think about whether to essentially, um, you know, force them to, because they don't have the capacity to make these decisions at all. Um, so especially on the second page, that table, the 7 questions in figure 1 are really kind of critical to think about and work through. But I think in terms of just like putting together the case, I do think I do see the tension of like radiographically that really looks like a primary lung cancer, but to have like this solitary soft tissue metastasis just in the breast, wow, I mean that would be unlikely. Um, and so I think some people would actually, it could be a reasonable argument that this patient may have 2 cancers. And, you could also think about kind of adjusting the pretest probability of that by thinking about whether the patient has a smoking history, thinking about whether the patient is at risk for developing breast cancer as a male from the family history or BRCA, genetic status, things like that. You could think about genetic cancer syndromes again if you had a better family history, right? And P53 mutated situations, you can get, lung, breast, bone, lymphoma, sarcoma, and but for the first case of cancer in somebody with Li-Fraumeni syndrome to happen in the 8th decade would also just be very, I think it would be unusual. But and then the prostate cancer, just quickly, yes, it's probably there, but it has very likely nothing to do with everything else that's going on. It's localized, it's not metastatic, just based on the pattern of lesions we're seeing, the degree of PSA elevation, which is very mild. We think of as greater than 4 to be abnormal, but remember that's in the setting of like screening and catching cancers that are so early that you could, potentially benefit from early intervention, right? The one situation in which even a small prostate cancer can cause, systemic problems is if it's not an adenocarcinoma but a neuroendocrine tumor, which can arise in the prostate and can cause perineoplastic, manifestations, Cushing syndrome and SIDH and other ways that the brain can be affected and the rest of the body can be affected. But in this case, it seems like it's an adenocarcinoma. I think you almost definitely want to biopsy the breast just because it's so superficial and easy. And then the question is, do you also biopsy the lung, right? And I think just biopsying the breast first because it's an easier target and doing the immunohistochemical and other pathologic sort of testing that might localize and say like, okay, this is a lung cancer that we just found on the skin, as opposed to this is a breast cancer, and then you might still wonder whether there's also a lung cancer. But I actually want to put all of that aside and say, okay, there's the cancer issue, and then there's the reason that the patient was brought in, and right, the altered mental status, which I still can't explain. And that's where I think I would think about a couple of things. I would think about a imaging the brain better and actually considering a lumbar puncture to look for leptomeningeal carcinomatosis, which can, hide on the CT scan, but certainly can happen in lung and breast cancer. And then I would try to, again, optimize all of the metabolic things to, whether that's the glucose, the sodium, maybe holding some of the sedating medications and things like that, just to see with that subtraction, whether things might get better and how big and how heavy the problem of the altered mental status will still be, as in how much of an additional explanation it will still require. Because as of right now, I think it still needs a big explanation that we haven't found yet. I'll stop there.
All right. Well, that's outstanding. That's outstanding because we face like the same difficulties that you guys are pointing so far. And Youssef made a lovely comment regards the ethics committee and how to deal and to face those patients. I must reveal that this was the most difficult the most difficult patient I ever seen, and I couldn't have a clue on how to deal with it. Everything was super new for not even for me, just as medical student, but also from the residents and the attending. But I just want to comment about some topics that you guys made so far. So the patient was afebrile since admission, despite having a super high leukocytosis. As the days went by, the patient couldn't manifest any signs of like bacteremia or any etiology or source of infection. And we stopped all the antibiotics, and the patient remained well without it, despite still having the leukocytosis. There was also an unsuccessful attempt to a lung biopsy by IR, but there is a thing that before doing the before trying to biopsy the lung mass, it was done the biopsy of the breast mass, and it was sent to pathology. And then we started like calling day after day and pressuring them to release the results. And after almost 6 or 7 days, I don't remember specifically, they came with the results. The pathologist said that was a poorly differentiated carcinoma that was hard to stain. So they suggested that the biopsy of the lung would benefit the result of the malignancy, and then is when the case became to start to be more tricky, because then is where started the phase where we try to run the multidisciplinary meetings and discuss like harm, if the harm outweighed benefits and everything. And like pulmonology was very certain that there was a lung, that was a lung cancer. And the other team was, I don't remember specifically, but it was certain that it was a breast cancer. So we did the multidisciplinary meeting, and it was a consensus for all the teams that due to the fact that the harm would outweigh the benefits, and the patient couldn't have a surrogate make a decision maker, and it was decided by hospice for him. And other than that, for the procedures that was done before, it was done via two, I think that is two attending approval. I don't, there's a specific name for that. And there was also a lot of nuances of this case that I will say now. That is, psychiatry tried to manage the auto-augmentation. So the patient with the passive days, he started to waxing and wane, but in all those moments, his speech was slurred. It was very difficult to comprehend, and he couldn't move out of his bed, and then he had also a lot of difficulty to ingest food. So we tried to put a care pack for him, and he became agitated. When the episodes of agitation, he removed the care pack. So we did once and we did twice, and due to the big tongue and the difficult airway, it was recommended to put a care pack through an EGD. But then the patient went there. They put the core pack, and before he moved him back to his room, he already removed the core pack. So then we discussed it again to put soft restraints, and it was not an easy decision to put the soft restraints, but in the end we did that also. So the case here, I want to bring that for you guys, because more to discuss an ethical dilemma instead of a super hard diagnosis to make. And I think that this encompasses a really difficult case that we need to put all the teams all together to try to find what is best for the patient, and always put like the patient's goals and acting in his best interest. So yeah, I think that I'll stop here. Yeah.
Thank you, Vinny. Yeah, totally agree. I think this is plenty complicated medically, but then the psychosocial situation and the ethical dilemmas are really hard. And sounds like you were very thoughtful about it and made as good of a call as anybody. Seema, do you want to summarize the teaching points, or does anybody else have anything else to share or any questions?
And yeah, Zaven, so just one quick comment that I forgot is that we couldn't explain why the mentor altered mental status, and the patient never went back, despite they revealing that he was AO ×3 before hospitalization. He never went back to his baseline, and yeah, was very unfortunate as also. So we don't have like a clear explanation. This is a real life case, so I cannot explain why there was the altered mental status.
Yeah, I can't either. I think there's as commonly there is still just a lot of uncertainty, in part kind of inherently to the case, but also because of how things played out, we weren't able to turn every stone and rule out every possibility, right? That we've mentioned, for example, as potential explanations of altered mental status connecting with the cancer. Yeah, it just wasn't feasible, right, to test for leptomeningeal disease or an immune phenomenon related to the cancer, or even just sort of smaller metastases in critical places of the brain that you might have seen with an MRI. And then in cases like this, I feel like there's also just, when we're missing a big history, you just don't know whether, what the nutritional state of the patient has been in recent months, right? Whether there has been recurrent trauma over time, or other ingestions or exposures. So I think there's still a lot of possibilities that we just can't answer or rule out, right?
Thank you, Winnie and Julia, for such a wonderful case. Winnie, would you like to share any final reflections before I bring the teaching points, or should I go forward with the teaching points?
Go for it, Seema.
No, yeah, thank you so much, Simi. I think that I made some reflections here, and please go for the teaching points.
Thank you, Winnie and Julia, for such an interesting case. And thank you, Lira, for scribing, and Yusuf and Zaven for such a wonderful discussion. And it was really nice how we talked today, not only about medicine, but also the ethical dilemmas that we face in medicine. And after this wonderful teaching, I don't have much to add, so I'll just keep the teaching points very, very brief. So we had this patient with altered mental status, and we were thinking that in someone who has history of diabetes on insulin as well as COPD, we should always think about whether it is due to hypoglycemia, hypercarbia, and also due to narcotics and medication that the patient is on. And then the patient also had this arrhythmia. So we were thinking whether it is just a part of a systemic metabolic syndrome, or there is something going on in the brain as well. And then we had this chest mass, and we were thinking that chest masses usually take time to develop. So this must be going on for quite some time. And we thought that sometimes patients do not have one malignancy. Both P53 mutations can cause patients to have multiple malignancies at the same time as well. And some altered mental status was something we were still thinking about, that whether it is something going to the brain as a consequence of malignancy or something systemic. And thank you so much. I got to learn a lot.
Thank you, Seema. Thanks, Lyra. Vinny and Julia, thanks for the great case. And thank you, everybody, for joining. See you all next time.